Okay, so we have 9 o'clock. Call the Neighbors of Dunn County Committee meeting to order. It's been noticed and we're all set to go. So I'll call the roll. I see Don here, Keeter, Larry here, Corley is here, and Sean Breslin is Zooming in. Is that correct, Sean?
That is correct.
So we have everybody. Next up, approval of the minutes. We've had a chance to look at it.
Can I interrupt for just a second? Can you do a quick roll call again? There's people on my screen that I don't see.
Oh, okay. Yeah, Don Keeter.
Okay.
Is here. Corley Witzel is here. Larry Bjork is here.
Larry Bjork. Okay, you're off to the side, Larry. Okay, perfect. Thank you.
That's the first time he's been missed like that. You know he's here.
Okay, thanks, guys.
Okay, I'm looking for approval of the minutes.
I'll move.
Don Keeter moved and Corley seconded. Any changes or additions? All in favor, aye? Aye. Any opposed? Carries. And then at the request, there's public comment. Do we have any public comment? Okay, none. And at my request, I asked for just an organizational chart, a little explanation of how the neighbors run, because I don't think any of you have seen that, and I need to learn it too, at least have an idea. So Carmen?
All right. I am going to try to share my screen, which I have not done very many times. So there we go. See if I can get it so it shows. Oops. Okay. It's a little hard to see because can't get it to try and get it bigger and scroll in and out.
Yeah.
Okay. So I have our organizational chart for the neighbors. This is actually recently updated just to reflect our current FTEs in all of our different departments. So when I go over this during orientation, I do explain that we have slightly different titles than most skilled nursing facilities. This was created when the neighbors was built to have more of a mentor title than hierarchy title, so it's more team orientated. So we do have a few different titles that do typical nursing home roles, but just are called something different. So for example, my title at the neighbors is community mentor. But technically speaking, I do hold the administrator's license. So depending on who I'm talking to, if it's someone from the state or things like that, I just say administrator because that's the more recognizable title. But for the county, it's community mentor. Off of myself here on our chart, we actually have our medical director who's here with us today. So we have a medical director that we have contracted through Mayo. Currently that is Dr. Phillips. So he's actually here. Then we have a clinical mentor. So I'm going to go through each kind of department one by one. So we'll go through nursing first. So we have a clinical mentor, which would be similar to the director of nursing at a traditional skilled nursing facility. The clinical mentor position would be in charge of the overall department of nursing. This position is campus wide. So similar to mine, there's only one of this position on campus. So oversees the overall campus, not a specific neighborhood. Kind of adjacent to that, we have staffing coordinator. That individual does the staffing schedules, works with the CNAs, nurses, homemakers, creates the overall daily schedule for the 24-hour operation of nursing. Then we have 3 assistant clinical mentors. Assistant clinical mentors, if we look at it as a campus, would be similar to assistant directors of nursing. So they oversee certain department or certain sections of nursing department. If we look at it as a neighborhood to neighborhood, which is how the state looks at us as 3 separate skilled license nursing facilities, that would would be some more similar to a director of nursing. So it's kind of in between, depending on if we're looking at a campus view or if we're looking at each individual neighborhood. So when the state comes for our survey inspections, each assistant clinical mentor would be responsible for their building. So there's one for each neighborhood. Then we have an additional position that is someone who fills in one of these other positions, but has an additional role of what's called a household coordinator. So on campus, we have 9 households. Each of those households, when they're in operation, currently 8 of them are, has a household coordinator. This is someone who can be any position. Typically, it's been CNAs. We have had some nurses, could be a homemaker, could be a social worker. It could really be anyone that works in that neighborhood or household. That's kind of the go-to for that household. So they help with orientation, they help with training, they help anytime we have to implement a new policy or procedure. They are there to help with resident wants and needs that might be above and beyond a regular CNA task. For example, they sometimes plan parties for residents. When we have our Christmas parties, they're directly involved in that, things like that. So they do make an additional wage on top of their regular wage. So it is a paid position, but it is not a full separate position. Then going down a little bit further, we have unit clerks. That position does things like creating charts. They help with admissions and discharge paperwork, any sort of appointments, changes in orders. So when the physicians change orders, they help enter those in. Homemaker or host, that is similar to what's called a universal care worker, with the exception that they do not do any direct CNA care for residents. So they help with food preparation for breakfast, as well as serving meals for lunch and dinner. They do some laundry, housekeeping in the households. So it kind of encompasses a bunch of different positions from the more traditional skilled nursing facility model, where we'd have separate laundry staff, housekeeping staff, and dietary aides. So we have them directly for each household, and they kind of encompass all of those positions. We have certified nursing assistants, which provide direct patient care for all of our residents. We have LPNs, which is a licensed practical nurse. So it's one of the 2 kinds of nurses we have on campus. And then we have staff nurse, which is the same as a registered nurse. The reason that ours say staff nurse is there's a few different nursing positions across the county, and we had to have different titles for each. So public health employs nurses, DHS employs nurses. So we just kept them separate since there's a few different RNs employed by the county. So we have staff nurses. And then purchasing and supply worker, that would be our purchasing department. So working on purchasing for our medical supplies, cleaning supplies, office supplies, anything like that. So work directly with our vendors. Now I'll go through a couple of the other departments. So director of social services, or social services mentor, is the director of our social services department, as well as does our admissions. So working with the hospital directly on getting residents into the facility, whether that be short-term or long-term residents. And that individual oversees 2 social services or social workers. Currently, we only have 1 social worker working under the director of social services. But we do have a full-time social services position open that we have kept open because of our lower census at this time. We have a human resources associate. So that is Chris, who you all have met or at least seen on Zoom. We have life enhancement mentor. So that would be activities. So resident life enhancement, doing outings, activities, working on the fundraising projects, anything resident focused for resident entertainment. Then that department has a couple of other positions. So we have, oops, not getting to the bottom. There we go. We have life enhancement assistant. So that is a part-time position that fills in to help with activities and programs for the residents. Then we have a full-time music therapist doing music activities with residents. And then we have a full-time recreational therapist, which is the therapy version of doing recreation activities, doing a lot of games, physical activity with residents, things like that. I'll go over. We have health information manager. So this individual does our ICD-10 codes, which is coding for residents' diagnoses. So that is how we get paid through Medicare and Medicaid systems, as well as keeping track of all of our charts. So residents or their families can request charts from way back that we have to provide documentation, or we could use it for if someone's coming back to us, if a hospital needs it. So management of all health information goes through this person. And then the dietary department. So we have a culinary mentor. So that would be our dietary manager. This person oversees the kitchen, oversees ordering of food, and works directly with the dietitian to create menus for residents, as well as helps with overseeing our senior meals program and contract. We have a lead cook. So this person is a lead cook in the kitchen. So directly working with staff in the kitchen, works with the menus, works with recipes, and then leads the kitchen in the development of the actual food. We have cook positions. So that would be assisting with the lead cook, as also on the days that the lead cook is not there. So doing the actual cooking of the food. We have food service workers. So these would be other kitchen staff that would primarily deal with prep of food. So cutting up vegetables, prepping desserts, doing different things that then assist the cooks, as well as doing things like cleaning dishes, organizing food, bringing food to the households, since we do have one main central kitchen. So the food all has to come out of the kitchen and be dispersed to all 9 households. So the food service workers do that. And then, as I mentioned before, we do have a full-time registered dietitian. So we have a dietitian that would assess the residents' food needs, attends care conferences to make sure that the residents' needs are being met, does the assessments for dietary needs, and then also works with menu creation for both the residents at the neighbors as well as the senior meals. Does anyone have any questions about our organizational chart?
Oh, you put your.
Mr. Chairman, question. Who does the purchasing for the health, for the whole facility? I mean, is there a separate purchasing agent for the food part and then for the other supplies?
Yep. So for food, it would be the culinary mentor does the food purchasing. And then right on the bottom here is the purchasing and supply worker. Okay. So that person does the purchasing for anything else. So medical supplies for residents. So anything from incontinence products to shampoo, and then wound care products, as well as like office supplies. So she puts in our staples order, anything like that. And then any department that would need to purchase anything would do that independently. So for example, our life enhancement mentor, Alyssa, does the purchasing for activity supplies. So the only thing that goes through the main purchasing department is nursing, and then anything that would be used by the whole facility, like office supplies.
Thank you very much.
Did Sean say something?
No. Oh, sorry.
You can sure hear well. I hardly said that. That's good. Thank you, Carmen. That gives us an idea. And as time goes on now, excuse me, the next few weeks, she's going to put some names with these. So we've got Mike or Dr. Phillips here. We put a name with that and go along, and we'll see, kind of work our way down a little bit as people are available or can Zoom with us. So thank you very much.
All right. Then we'll get started with our regular items. So Quality Assurance Steering Committee. So we did meet last week. This meeting was very brief as we didn't have most of the committee there. We had a few people out sick and then a couple people on vacation. So we actually had to table a lot of our normal items. So there'll be a larger report next month for Quality Assurance Steering Committee as people weren't available. We did go over COVID related things, which I will talk about a little bit later as well, but there was nothing, anything new or exciting in that committee this month. All right. Any questions on quality assurance? Employment activity report. So I'll have Chris hop on to do that.
Morning, can everybody hear me?
Yes.
Okay. So for June, you have this in your packets, but I'll just kind of go through the highlights of it. So for types of recruitment, kind of the standard, you know, the ongoing ads on the county website and NeoGov. I did do the job fair at the Judicial Center in June. That's kind of one that usually is like a quarterly thing, and I think this is the first one since COVID that we've actually had a physical job fair. So it's kind of nice to get back involved or have a presence out there again. Number of interviews for direct hire, we had 11. For agency, we had 12 positions offered. We had 4 positions accepted. Were 6 we had, because some of those were kind of tail end of May into June. Positions offered at higher than a step 3, we had 1 person request a higher wage than what we were able to offer. Resignations, so for the month of June, they're listed here. Some school, you know, just getting out of healthcare. We had a couple of full-time, or a full-time LPN and a part-time RN that retired. And then at the bottom, you'll notice that there's just some people that don't return from a leave and don't contact us back. And at some certain point, you get them off the books. So those are the ending of that. So open positions would have been adjusted kind of with our staff coming on and agency coming on and contracts ending, stuff like that. Number of leaves of absences that really fell in June, obviously, because we had a whole bunch of students that had returned for the summer. Go down to work comp lost hours. We didn't have any missed hours for June. A number of missed shifts due to COVID-19 issues in June. A little bit of an uptick in that, was about 68 missed shifts, or roughly 550 hours. You know, it's never an exact science on hours because we have a lot of different shift lengths and structures here. So that's, you know, pretty close as I can get it as to how many hours missed. That also does include agency staff that would have missed due to COVID-19 issues. Does anybody have any questions?
No, it looks fine.
Okay.
All right. Thanks, Chris.
Yep.
Next will be the resident referral report. So that's on the back side of the employment report. So number of residents in the facility at the beginning of the month was 104. We had 100 referrals this month. So that is actually a decline from what we have seen over the past few months, still much higher than it was pre-COVID, but less than what it had been over the past few months. We had admitted 10 residents. 1 was still at the hospital during the month. Number of residents not admitted was 89. As normal, that does not equate exactly due to some being readmits. Number of residents in the facility at the end of the month was 111. So we are creeping up a little bit more. We had been hovering right at the 100 mark. So we have been able to put a few more residents into Fireside. We have made sure to remain at the level of being able to staff. And we have not opened Arrowhead yet, but we have been able to accept a few more. We've had 0 residents transferred to another facility. We did have 4 deaths this month, and we had 3 residents discharge. So we are seeing a few more residents discharge, as we are having people stay in our short-term households again. So then that will see discharge. It's more in and out than it would be when we were only admitting to long-term care households. Our referral sources were the same, always the 2 Mayo hospitals and Sacred Heart. Does anyone have any questions about referrals?
Looks good.
All right. The next item is environmental and facilities report from Scott.
Good morning, everyone. Not a lot to report. We've had a changeover in one of our express custodians. one that had been with us for a while did leave, and I did have a replacement start beginning of this week. So that was a quick turnaround. Keeping the cleaning going. Other than that, it's been working on keeping things going. Work orders, guys have been busy. Had some events going on with tents and that yesterday, and the wind blowing kept them busy. But Brady and Bob are doing an excellent job keeping things going, and still waiting for that state to show up for that survey.
Just one personal comment is it was Brady or Bob. They helped out with the ukulele group. I think it was yesterday. Yeah. Get power. So my wife was very happy about that.
Good.
Nice job.
Thanks.
All right. Thanks, Scott. The next item is Cna Class general update. So later on the agenda in the considerations for action, there is another item regarding this, but I wanted to have a general discussion about this before we got to the actual action item. So we've had a couple of different movement in the Cna class update. So as we've previously discussed, one of the ideas was creating a separate position that would be able to have the Cna class person trainer be a full-time position that would also have some other duties, training staff that are current staff, doing audits, compliance stuff, getting some required trainings done, our annual skills fair, things like that. And that is what's later on the agenda. Since our last meeting, we've also had kind of a development of a potential of another opportunity that would be someone coming in and being not an NDC employee doing training at the neighbors. There is some other nursing homes in our local area that have had a separate company basically use their nursing home as the training site and have what's called the Cna Institute. So I did attend open house at one of those, and they are interested in expanding. So now we have a couple of different options, which is better to have more than one available option. So we are looking at different ways to do that. The only downfall of that would be the person would only be doing in-house Cna training. They would not be doing training of our current staff. So there's kind of two different options there. That would be something that wouldn't be at cost to the facility though. So kind of a two ways to look at it. We would get more out of having an internal staff person doing the training in terms of current staff development and training, but it would be cheaper to have someone else come in. So later on in the agenda, there is an item about endorsing a creation of that position to then go to the Committee on Administration. The idea behind doing that would be until we actually hire someone, it would not cost us any money. So getting that groundwork in there. And if we end up going the other direction with the other program, we wouldn't be out much besides the time to go through the process. So trying to make sure that we have our ducks in a row depending on which direction we go. So does anyone have any questions on the general update?
Well, thanks for going over in Chippewa. Okay. Yeah.
All right. Next, I will go over the COVID-19 update. Not much has changed since our last meeting. We still are doing all of the same precautions and procedures. If we have any positive cases in staff, we have not had any positive residents since our last meeting. Knock on some wood if we had some. We've had a few positive staff members. So as always, when that happens, we have to go into an outbreak in the areas that they worked. We did have an instance of a staff member that had been in nearly every household on campus. So that was a little bit of a stressful week to figure out where they had been and who they had been in contact with. But we have been managing that the same as we have for the past year or so. Not much has changed in the terms of how those are handled. We are still considered in a high transmission rate for our area. So staff are still wearing masks as well as eye protection. It is a requirement if you are in substantial or high to have eye protection. Masks are required no matter what level of transmission we are in. So not much has changed at this point. I do know that there is some conversations at legislative levels about trying to get some of the restrictions lightened, such as eye protection, but that has not come out as an actual regulatory change. So we are still required to do that. In terms of visitors or anything like that, visitors are still all welcome. They just need to be screened upon entrance. So I know that's a common question that comes up. So even in an outbreak, visitors are welcome to come in and just have to be screened at entrance and wear a mask while in the facility. Any questions on any COVID-19 situations?
Larry?
Well, not on the COVID-6. Are you about fit? Was that the last year's report?
Yep.
Okay. Well, I'd like to jump back to the referral activity report.
Sure.
And you're probably aware that the county board had quite a discussion, input from the community on, well, not referendum, but question on the ballot as far as support of basic health care.
Mm-hmm.
I can't remember the term, universal health care.
Universal health care, yep.
So, you know, I read through the reasons for not admitting, had 89 not admittings, and, you know, not residents of Wisconsin or Dunn County or no insurance were the three that kind of stuck out. And I have no idea, you know, where universal health care may come or may go. But if there is a type of universal health care, how is it going to affect your industry in Dunn County in particular, do you think? I mean, if everybody has coverage, is there just absolutely going to be no bed space available, or what do you think?
That's a good question. I guess it's a little bit of a loaded question. I don't know
I just
exactly.
don't know where to go on.
Sure.
And you don't have an answer. Larry, we all recognize you don't know that. So
Okay.
Right.
My assumption would be that there would be specific parts of that structure, whatever the government would create as a universal healthcare structure, that would lay out specifically what is and isn't covered. So I don't know if there would be certain requirements, if there would be certain reasons why, if there would be certain ailments that specifically required, if it had to be a doctor signing off. It still does have to be a doctor signing off that they need us at this point for any sort of government funded healthcare. So for someone to come to us for Medicare, Medicaid, we have to still have a doctor's certification. So I'm not sure how that would work. At this point, with that huge number of referrals not admitted, is primarily based on staffing. So the reasons down below is what we typically have, but there used to be pre-COVID. I know that this committee, the majority of you didn't see our reports pre-COVID. We listed out specifically the number of people for each reason. But now, because we don't admit so many people due to either COVID situations, staffing, or just bed availability in general, we don't list those out specifically. So when it comes to the no insurance right now, that's typically someone that has no payer source. So they aren't going to be certified under Medicare for whatever reason it might be. And then they don't have either private payer source or Medicaid or any sort of like HMO insurance plan. So it's basically we get a referral that says we don't have any way to pay you. So then obviously we can't admit that person until they go through the Medicaid application process. So that's where that no insurance comes in. I'm not sure exactly how that would work. If there was universal health care, if we would be directly paid by the government for people that wouldn't have a separate payer source, or if it would be kind of like Medicaid is now, would be a kind of a payer source for them. I'm not sure how it would work, but I'm sure there would be very specific guidelines that we would have to follow for admissions.
Carmen,
Yeah.
well, when
Yeah, the point that you can't answer the main question, but the other question you had is kind of when we don't admit them for no insurance, how would that affect in the future? Is that kind of what you were asking?
Yeah, kind of. And I was kind of getting at a little bit that, I saw in your numbers that veterans, how many veterans. So I'm just trying to put into my head as far as the pay package that comes with a veteran. Mm-hmm. Would that be would you think that would be, do our veterans have federal insurance that says, if you need it for healthcare facilities like yours, that the federal government pays it?
For our veterans admissions, they have to have very specific criteria to be admitted under a veterans contract. So a lot of our VA residents are hospice residents. That's the most common VA contract for a nursing home. And then there's other very specific things. Sometimes we have residents that are admitted to us under private pay or Medicare, and VA's their supplemental insurance. So they'll pay for therapy or other things like that, but not the actual stay. So VA's insurance coverage is very different than a lot of our other insurance coverage contracts. I would not think it would be similar to VA just because VA doesn't cover as much as what Medicare or Medicaid covers, depending on the person's needs. So I would think it would be kind of somewhere in between those things would be my guess.
Right. I wasn't going in any direction with it. I just don't know.
Hey, Jane, did you have something?
regarding some of the insurance, when we say they're not accepted because of insurance, we have a couple Medicare, Medicaid plans. Well, let me start with, everybody gets their Medicare when they're 65, but they have an option to go to this Medicare Advantage, which is a subcontract basically of the Medicare benefit. We then become in-network or out of network with all these other insurance companies that administer the Medicare program for, if you want to contract individually with them. And some of those we are not in network with, and most of them we are. So it could be that somebody has Medicare coverage, but we're not in network with who they chose to administer their benefits. And that could be similar to how universal healthcare might work. The actual government doesn't administer.
Excuse me, I think we'll keep it off of the universal health care because that's not.
It's administered by different
but
groups,
that's not anything we can answer right now.
Right. So it becomes more complicated.
All right. Is there any other questions for me on my general report?
Did you go to 7A yet? I can't remember.
No, we haven't gotten there. Okay. Just got done with 6.
Okay.
All right. So next we'll move on to 7.
Oh, okay. Yeah, here we go. 7A, and this is what Carmen referred to as creating a position. And I think throughout the different departments in the county, there are positions that aren't filled. I know their environmental services has several, but sometimes we have created positions looking towards the future, knowing that we might not fill it now. And that's what you're talking about with this one. You all got her sheet, I think. And Carmen, you adjusted a little bit. This would be a position that would be partially for LPN training and partially for training and doing other things for the neighbors. And might be half and half, might be 40-60, we really wouldn't know. And it would cost money. Okay.
I can give a little bit more of a description if you would like.
If anybody has a question.
Yeah, I was just wondering if we wouldn't go with an in-house person, then what happens to a training of your staff? That doesn't happen then, or is there some other way of doing it?
We would continue doing it how we are now, with having the nursing managers or myself, or we do have a CNA trainer person that does a lot of our audits and things like that. She doesn't train the course. She's actually a retired CNA from the neighbors that comes back and helps out with doing like hand washing audits and PPE audits and things like that. So it'd be a combination of current staff and her that would continue doing how we are now. If we went the other way, creating this position would just open up more training opportunities that I think is a need that we do have. Is right now it's kind of becoming an addition of other people's jobs, and it would be good to have a good focus on it. It's one of those things, and I kind of explain it in the report a little bit more, that we can't directly see the cost of not doing it because it could relate to having more citations or having fines, things like that. It hasn't yet, but there are more and more regulations that are more scrutinized, especially infection control, that if we had more training, we could avoid those in the future too. So that would be the potential trade-off there, is that we wouldn't have an additional person to do that training.
Yeah, it would seem to me that probably a lot doesn't get done if it isn't assigned to a specific person.
Yeah. So I can speak a little bit, Mr. Chairman, if you would like, about the cost, as well as kind of the general idea of how the process went for this. Okay. So in the report that Jenna and I created, it basically goes over the idea of the position would be to be the CNA trainer for the course, as well as being a staff development person working on training with our current staff, RNs, LPNs, and CNAs. The required position is an RN position that would be for the CNA training. And then this person would also be able to train RNs and LPNs. Our current training staff train CNAs and other staff. They can do PPE audits and things like that, but would not be able to do, for example, return demonstration training on IVs. So for that, we're currently using our nursing managers, as well as some, if we ever have additional nurses, to do those trainings instead of having a designated person. This position did go through the full process of being graded on the wage scale. So it did result in a grade N, which is described in the report. This position, we did for just the basic cost analysis of the position. We started at a step 3, as it's better to overcalculate than undercalculate. If someone would be to start at a step 3, fully benefited for 2023, the position would cost $96,194. So that includes health insurance, as we wouldn't know if the person would be taking health insurance or not until they would start. So that is the overall fully burdened cost. In addition to that, we don't have exact numbers because it would be fully based on how many students we have enrolled and how many of them would be part of the WIS Caregivers program, which is a program that I know we've talked about in the past on before this committee was created. I do not know how much we've talked about it since the new committee, but is a program through the state that is intended to develop more CNAs in the state of Wisconsin. It is a program where the students would get the class paid for, as well as a bonus after they work for a facility for 6 months. We did participate in this program the last time it was created. So a few years ago, I believe it was 2016 was the first year it started. It ran for a couple of years and then kind of fizzled out. We did have some students through that program. And then now they restarted it. This time they did change a couple of things. One of the changes is that the facility that has the students and trains the students does get a $300 bonus for every student they produce. So that would also be on the other side of things. So if we have students that are coming to us, we do have direct costs from the students. So the students would either pay for the class itself, which would have some offset of the instructor fees, as well as if they were WIS caregiver students, the state of Wisconsin would pay for the class, and then we would also get that bonus once they complete the class. So I don't have exact numbers, as we don't know how many students would be enrolled. We don't know how many of them would be part of WIS caregivers, but at least we have some knowledge that it would offset that cost. So it would be lower than the $96,000. In addition to this is similar to what we talked about with the PM homemakers. I know that was on the last committee as well. The idea is to also spend money to save money a little bit. So CNAs is our biggest cost when it comes to agency cost. We'll see that spreadsheet in a little bit. That is the primary spender for agency costs. We need the most of them, and we have a lot of agency staff. The main goal of having a CNA in-house program is to create more CNAs and have them work at the neighbors. It is fairly common that people that do their CNA training somewhere and have clinicals there, if they have a positive experience, that is where they end up working if they choose to work as a CNA. That primarily, that is the majority of the students. So we would have potentially more in-house staff, and then that would lower the costs that we are currently spending for agency staff. Again, that isn't something that we can project exact numbers because it would be based on students, but it is the idea behind having the in-house CNA program. As well as increased staff training would also potentially help with retention of our current staff. So that would be another benefit of having someone there to train the staff. In terms of process, this would be an endorsement from this committee, and it would go to the Committee on Administration, as all personnel related issues go through that committee, and then would go to Exec and County Board for final approval.
Supervisor Keeter.
I was just wondering, maybe I missed this before, but you mentioned another outside program in Chippewa.
Yep.
Now, would that cost us money to get people from there then?
As of now, I do not believe that would cost money. The only thing it might cost would be if there's some sort of setup fees for any equipment that we might need that they use that we wouldn't use, kind of thing. We do already have the space set up to be a CNA training program as it had been in the past. So we have the mannequin dolls that they do practice trainings on. We have the supplies, the CPR stuff, all of that. We have on site as we had a CNA training in the past. So I don't believe they would need anything else. But they would deal with all the money coming in and coming out for the resident or for the CNA students then, and they would just use our facility. So I do not believe it would cost us money.
But we have no assurance that those CNNs would stay here then. I mean, they can go any place.
They can. And so they still could go any place with this program as well, unless they were part of the WIS caregiver program. Once they started with us, then they're with us for 6 months. Otherwise, they don't get their bonus, but that would actually be having to start employment. So even if they're trained with us, say, for example, they don't live in Menominee and there's a nursing home in Woodville, that nursing home, and they don't have a CNA training program, they come to us, but they want to work there, they still could go there. It's just very common that CNA students stay where they're comfortable. They learn the facility during training, during clinicals, everything like that. So we wouldn't retain all of the students that came through the program. There's also many CNA students that never work as a CNA. It is a requirement for a lot of college programs now in the healthcare industry, but it isn't a requirement to necessarily work as a CNA. It is a requirement to take the class. So it might not everyone that came through it either way would stay with us, but hopefully some would.
Anyone else have ideas or questions on this position?
I do.
Oh, Supervisor Breslin.
So if we use them for CNA, okay, you use this person, we create the position, the part for the CNA, about how much more or about how much of their time would be spent on ensuring our other training is up to speed, infection control and all that?
I'm not 100% sure at this point because it would also depend on the number of students and the interests we had. We could base it on anything that we kind of want to. We could limit the amount of classes that we had, and then that would free up more time for other trainings, or we could have as many trainings as we can fill, our CNA classes as we can fill, and that would have less time for training for other staff. So that's still up for discussion and trying to figure out the best plan, as well as it would take us creating the program and seeing how many students we're going to get. The main idea behind the program, behind the position, was the CNA program. So my thought would be to have as many class opportunities as we can. Also, obviously, whoever filled the program, we would have to be considering their schedule and things like that, as well as typically CNA classes, except for in the summer. And currently on our calendar, this would probably not happen in the summer. CNA classes are typically in the afternoons, weekends, different things, so that students, high school and college, can attend. So they're kind of off schedules as well. So that would be another consideration.
All right, thank you.
Mm-hmm.
Supervisor Bjork, did you have a
Thank
question?
you, Mr. Chairman. Yeah, I just had a question on how many students would be considered a class, and did you say how long the class or hours of training it would be to complete the course?
Sure. The course is 75 hours. That is a combination of book work, or how we have it set up right now is to use Ready CNA, which is a virtual training for the book work part of it. So it's learning anything from direct care to residents' rights, regulations, bedside manner, things like that in book work. And then there's also clinical and skills work. So in total, it's 75 hours. The skills and the clinical would be in person. And then the other part of that would be virtually through a computer system that trains them through modules of videos and has little quizzes and things like that. And in a class, it can be set up multiple different ways. We could have very small classes. We could have larger classes. If we did have larger classes, it does require a second person to be physically there helping with the training. So then that would require one of our nurse managers or another nurse to be observing. I believe the regulation is if it's more than 8, you have to have 2 RNs supervising to make sure when the students are out on the floor working with residents, because they do work with our residents for the clinical part, to make sure that they're being observed and not having a bunch of students with lack of supervision. Mm-hmm.
Now, I'm thinking of a story. Dr. Brown, the former director here, said that, what was it, 10 or 11 people signed up for a course over in Elmwood or someplace, and 1 or 2 finished. So that's just the way things happen too. That was a good question, Larry. So if we had 10 people, that would make the cost go down a little bit, but then we have a limited number of people because we have to supervise them. Okay, so let's say you had maximum size class, everything went really well, they're all in the right, signed up for the right stuff. How much less would this $96,000 be?
So if they were part of the WIS caregiver program and we had the 10 people, it's $300 per person. So then we would have $3,000 that would come back through the bonuses. When it came to the actual cost of the class, that would also be up depending on how much we charge for the CNA class. So we do have to pay a fee per student for the use of that program. But then we could charge more money for the class. That would also depend on deciding how much as the county's CNA program that we wanted to charge for the class. So typically classes range from $475 to $600. It depends on where the class is. So the cost of the actual program is $470 per student. So if we charge $500, we'd get $25 a student. And So it kind of depends on how we set that program up as well.
So best case scenario, maybe we'd get $10,000 off of this 96
Per round, yes.
per round. Yeah.
Yep, per 75-hour course.
Okay.
Any other questions?
Now, there are several things we can do with this. We can say, let's move it on to the next committee. We can say we don't like it. We can say, let's think about it a little more and look at it again. Anybody have any ideas?
I guess I'd suggest we move it on at this point. It might take a little time or a little effort by the administration committee, but I mean, nothing's going to happen until we do get this through and then we look at it again. That's my understanding. Yeah.
Supervisor York?
I would also suggest that we move it on. Simply, I think as far as our staffing issues that are not going to change in the future, the more people that we can get involved with, what we offer at the neighbors as employment, you get people into the door and get familiar with the facility, that's got to be better than not having people in the door and getting used to the facility. So I would support it for the fact that it, hopefully that it would help in our staff shortages.
Supervisor Breslin, did you have a comment?
No, I totally agree. We need to move it on to the committee. The CNA program's not going to get any
I agree.
less booked. So
Likewise.
Okay. I would hope, though, that we don't look at this and then ignore the opportunity with the educational one, because the chances of getting this approved as a position are pretty good, but the chances of filling it and paying for it are not good. So I hope that you would. Okay. So we have endorsement of the creation of RN training specialist program. It's an action item. I think I would like to have a first and a second to move this along.
oh, first.
Okay, Sean was in there and Don was in there. Or Sean and Corley, Chris, whatever one you want. They're all right at the same time.
So Supervisor Breslin made the motion and Supervisor Witzel seconded. Is everybody good with that?
Yep.
I'm good with
Okay,
it.
thank you.
Okay, we have a first and a second. We discussed it a little bit. Any further discussion? Okay, all in favor of moving this along to the admin committee? Aye.
Aye.
Any opposed? No, unanimous. Okay, thank you. So that's one step, working on that CNA thing. Next up, we have a review of vouchers and financial reports. Jane.
Hey, do you have any questions on the vouchers?
I did. Let's see. I think. No, I don't. I was wrong again.
Okay. So then to the reports that I've added to the packet, if we start at the beginning of where I printed it, the aging report. We showed 3 months at a time and compare the outstanding balances, which are a little bit on the increase right now because of staff training. And when the actual payments come in, a lot of that Medicare money, which is a bulk of what we get, comes in right now, like the 3rd or the 4th of the month instead of the end of the month. So just that 3 days difference in supplying submitting the claim changes the aging report. So, but otherwise it's stable. We're not having a lot of write-offs, and I think it looks good. Any questions on the aging? The campus census, we're having better months. When I look at the average census, the total occupancy in June was 76%, where the average occupancy is 72. So we're on the rise. Central's census has risen. They'd have a 36% average, and in June they had a 44%. So that helps to increase the central occupancy. Any questions on that? Then the income statement for the campus. When we look at that, the actual year-to-date revenue is $6.5 million. We had budgeted $7.3 million, so we're at an $800,000 deficit for revenue. And then we go down to the total expenses. We've got 6.7 in expenses, and the budget was 7.3. So we are relatively we have more expenses than the difference in the revenues. So most of that is due to the nursing budget, and then some things that go to operations and management and maintenance of the plant are posted early, like insurances. So they will level off. The total estimated income or loss is a loss right now to date of $256,000. That's $60,000 above that. That is the facilities labor that just hasn't posted yet. So I don't want to put that in the numbers above because it hasn't been put through our payment system. I know Scott has his staff member out on leave right now, but that's about what we run, about $30,000 a month for facilities labor.
Jane, was that always up above?
Yeah, usually that gets posted directly and it's timely. So,
okay.
Yep. It's just absent from those numbers. So I wanted to make sure that went in there. And the depreciation is posted within the property ownership and use. So that's pretty much right on. So it's not really a cash flow report. It's more of an income statement report that includes depreciation, which is a non-cash item. Any questions?
Is there any ARPA COVID money coming in that's included in our income in this?
No, we have not posted any COVID dollars in 2022. We posted quite a bit in 2021, and we haven't posted anything in 2022 to date.
Thank you. Anybody else? No, that was for the whole campus, and we had asked you to do each one separately too, so that we can see them. Any of the supervisors want Jane to go through each individual one? Larry, Corley, Sean?
No, I'm good. Thank you.
Okay.
At one time you'd asked for more detail on the that second sheet of say the campus report, the year-to-date and the budgeted days, which is more of a census report and dollars for revenue per day. If you look at that second sheet about 3/4 of the way to the right, there's a column called rate. And that is our average rate per pay source. So this, if you look at the $623, that's a consolidated rate for insurance and the Medicare Advantage products, which have more expense included. That's like a full, a consolidated revenue. It includes the therapy, pharmacy, nursing, everything. Where the other rates that are like in the 200s, those are just for room and board. Medicare A average rate is $578.94. And again, that includes all the costs that go with that include the labs, x-rays, therapy, that kind of thing. So that's why you have a difference in those average room rates, because they are really measuring different things.
That 600 or that rate, that's per day per resident? Is that for every day, or does that fluctuate a little bit because of say you don't have x-rays every day and stuff like that?
Right, that fluctuates greatly. The And then we post the revenue on what we expect. And then maybe 2 months later, the insurance company pays and they pay a lesser rate. So then we have an adjustment. So that's a pretty volatile number. If you see, there are only 49 days that make up that number. So it's a smaller percentage weight-wise of our entire budget.
So the next number down, 267, what does that represent then?
That is the Medicaid family care rate. So it's just room and board.
Oh, okay.
And that fluctuates a bit now because Medicaid is paying on a person basis, not a flat rate per reset every quarter. So that rate varies per person now.
As well as that's an average for the whole campus. So different residents in different parts of the campus would be paid at different rates.
Yeah.
Just to point out that the one we're looking at here doesn't have any labels off to the left side.
I know, you almost have to.
And if you go down to the next one after East, that will give you all the labels. So the numbers are a little bit different. But if you scroll down and look at Healthcare Center just East, gives you an idea.
Yep.
Oh, okay.
So that's what.
Private pay rate average is 287.53, and the VA average rate is 252. The VA rate includes therapies and some pharmacy. So it's a little hard to measure the difference between the pay sources because they do include different things.
Boy, pretty complicated. Gee.
And thanks, Jane, for bringing it up to look at these. I've been meaning to ask about those. It is a little confusing, but that was a nice start on an explanation to help us start to figure it out.
Thank you. That's that report. And then the last report is the amount paid for pool staff through June. And that total dollar amount is 107. Oh, that's not 178,878 for June. The total paid is $1,664,840.
So as you can kind of see, it's almost every other month is higher, lower. That is not the actual trend is going up and down in number of staff. It's just the trend in billing and paying the invoices. So they all kind of even out to be about in between each of those numbers. But it's almost every other month based on billing and invoicing kind of things. So next month will be higher and kind of like last month was.
Yeah.
So it's not that we're going down in
number
of pool. We still have the same amount, if not more. And it'll kind of even out the couple of months that go up and down.
So our monthly average is $277,000 for pool staff campus wide.
Any comments, questions? Supervisor Keeter?
I assume the pool is more expensive than if you had a stable labor force.
Yes.
So that would be another plus for this CNO program?
Yep.
CNO
program. Yeah. So that's why in the report, it gives a little bit of a description of it wouldn't completely alleviate the cost as we obviously have to pay the normal wages, benefits, all of those things. But the cost of pool does have an increase compared to having internal staff.
Yeah,
And you haven't had the benefit of some nice information that Carmen gave us 2 years ago or whatever about the costs. So maybe we should bring that back sometime.
Sure.
It's scary, but we'll bring it back anyway. So through June, am I correct saying we spent almost as much as the entire year last year on pool? Just a little less, 150,000 last year.
That is true.
Okay. Larry?
I just wanted to jump on with Don there that, if we can find a way to eliminate pool with training, We gotta just rev it up.
Well, we've been working on it. How long you been working on getting the CNA thing done?
Oh, boy, I don't know, a year or two.
Oh, it's been longer than that. It's been long, but
yeah.
yeah, so it's been quite a while.
I would be very, if I can, I would be very cautious to use the word eliminate or trying to alleviate. I do not think that the CNA program is a fix-all. It is a good step in the right direction, and it's something we do need to do, and it will help. But I do not foresee it solving the problem. There's a lot more to the CNA shortage nationally and locally and at the neighbors than just not having the CNA, but it is a step in the right direction and a good thing to have. So similarly to, I know most of this committee wasn't here for the PM homemaker situation, but that was the idea with that too, is it's not going to solve things, and we don't want to paint too rosy of a picture of we get this, it'll be fixed, but it will help things definitely. So I just want to make sure we're realistic on that.
Okay, Jane?
I don't have anything else for the financials.
Okay, and then we just have the vouchers. A chance to look at the vouchers. I would questions or a motion to accept them from someone.
I'll second.
Okay, Supervisor Breslin also thinks we should pay our bills. Yes. Any other discussion? All in favor? Aye.
Aye.
Any opposed? No, that's all of it. Any announcements? Anything else? We are adjourned. Thank you for zooming in, Sean, and everybody else for coming down here.